Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a very hard cataract. The patient is totally deaf and the peribulbar block has not been good. So there are many challenges in this case. Let us observe this surgery. This is a totally unedited real-time surgery. The main incision has been made at 11 o'clock on the posterior aspect of the limbus. A side port has been made on the left side of the main incision about 2.5 clock hours away. An air bubble has been injected and then trypan blue dye is being applied over the anterior capsule underneath this air bubble. This is phenocane and this is adrenaline. These agents are being administered to have a dilated pupil throughout the surgery. Now the dye is washed out. We can see the pupil has dilated little more by these agents. And now this visco, this is 2% hydroxypropyl methyl cellulose, has been injected into the anterior chamber and it is applied over the corneal epithelium for better visibility. And now rhexis with utreta forceps. The utreta goes in, the anterior capsule is scratched, the anterior capsule is healed, and a large rhexis is the aim in this case because the cataract is very hard, rock hard, almost black, cataracta nigra. And if we don't do a large rhexis in this case, nucleus management will be very difficult. The rhexis has been done. Now hydrodissection is being done. Small aliquots or BSS are being injected at multiple points, and then the nucleus is nudged. See, the patient is moving his eye, the block has not been good, the patient is totally deaf, cannot follow instructions. Yes, the nucleus has been rotated. Visco again, and now to chop this nucleus we need at least this amount of exposed part of the phaco needle. This is easy tip from Otley Cataracts 3 phacomation. Some superficial lens matter is removed so that the clarity of the operative field remains okay during surgery. Now this is submarine chop. The tip goes in just in front of the main incision, goes through the substance of the nucleus towards the opposite equator, and here I make a very nice crack. Rotate the nucleus 180 degree, do 1 or 2 scalps, go to a deeper plane and try to separate the two heminuclei. But in this case there is a stubborn leathery band joining the two heminuclei. Now I try to chop this heminucleus into 3 pieces and I get this small piece free, and immediately I emulsify this piece. Make another chop on this heminucleus, and this time these 2 pieces are not free. They are joined by leathery bands. One more chop to this large piece, and still now this piece is also not free. However, I could emulsify the peripheral portion of this part of the nucleus. Now I come to the other heminucleus, make a chop here. Emulsified this small bit. Go to the other part, chop it. None of the pieces are free. I just trim the peripheral portion of the nucleus. And now I come out. And now I inject visco in the anterior chamber, and then some visco is injected behind the lens. And now I take two blunt hooks. This is my chopper actually, blunt chopper. It goes behind, tint the pieces and tear off the band. The band joining the two heminuclei has been torn, but the other heminucleus, the pieces are still joined to each other. And now I go in and apply ultrasonic energy to the joining band here, and thus I make the pieces free. And then I emulsify the pieces. Ultrasonic energy used in this case is 90%. Flow rate is 45 ml per minute. Vacuum is 450 millimeter of mercury so far. In this case, I can see there is a sheet of epinucleus protecting the posterior capsule. So I didn't go to FECO 3 mode in this case, and emulsified the last piece also in FECO 2 mode in the same setting. And now to remove this sheet of epinucleus, I decrease the vacuum to 250 and flow rate to 25 ml per minute, and remove this epinucleus. There is a piece of nucleus at the side port. It is also removed. Now look at the main wound. It is absolutely clean. There is no wound burn. Even though we have used a lot of ultrasonic energy, we haven't used Ozil FECO, normal longitudinal FECO. Even then there is no wound burn. This is probably because of the nice design of the FECO needle of easy tip. Now in this case we have only one side port, so I use this 23 gauge Simcoe cannula for removal of the cortex. And this is a very gentle and very safe instrument for removal of cortex in complicated cases like in weak geniole. Now in this case we have selected a single piece hydrophobic acrylic monofocal intraocular lens from Hoya, and here goes the intraocular lens. This is a preloaded system and you have to screw out the lens, so I used visco to fill up the SE and bag, and the lens is delivered in the bag. Now with the help of a hook, the lens is dialed and the patient is constantly moving his eye. Patient cannot hear a word. Patient is deaf, totally deaf. However, he didn't move his head, and this much control of eye. Actually, block has been given, but still the block has not been good, and the eyeball is moving. But still, we can manage if this, with some patience, with some concentration to the surgical field, we can easily manage this. Now the visco that has been used has to be removed nicely. I have used Simcoe to irrigate the capsular bag as well as the antechamber, and then this is the bimanual irrigation aspiration for removal of visco. And now a bit of moxifloxacin is injected into the anterior chamber, and then this side port is closed by hydrating corneal stroma. The main wound has been constructed in such a way that it doesn't require any hydration of corneal stroma on either side of it for its sealing. And now this is the final lavage of the anterior chamber. And then the antechamber is nicely formed with BSAs and the cases concluded after checking the wound integrity with a cotton tip Johnson Bart and applying few drop of Moxie. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy and great surgical competence.